Assalamu alaikum. My name is Fahd bin Abbas. I'm going to be speaking about clinical presentation and differential diagnosis of a patient with stroke. اللي بعده. Okay, so as we know, clinical presentation of stroke varies depending on the presenting illness. So once we have the patient in the clinic, it depends on mainly the location, severity, the blood clot and bleeding. So if it's a blood clot, it's going to be ischemic, and this bleeding is going to be hemorrhagic. So just like before, just like our colleague said, that it depends on various risk factors, the age of the person, if he has any chronic disease, just like diabetes mellitus and smoking. بعده. Okay, so I've listed some of the common presenting illnesses that usually we see in patients in the clinic. So most of these lists is occurring suddenly without any before alert or something. So usually you're going to see patients with knee weakness or numbness in the face, arm or legs, so upper parts. Usually patients with strokes will present with a change in the vision of both or one eyes, and this is a very common point. A severe headache that cannot be explained, whether it's migraine or other types of headache. A quick onset of dizziness, loss of coordination, and a sudden problem talking or expressing words. So in ischemic stroke presentation, there's something called acute focal neurological defects. Usually, mostly, the most common one is hemiparalysis with 60 to 80%. Hemiparalysis is basically a unilateral paralysis. It's basically a weakness of one entire side of the body. So 50% of the body, as you can see in the whether the left side or the right side, the person will have weakness in the 50% of the body. It's mainly due to a lot of causes, whether it's a trauma, whether it's tumor, a stroke, or even congenital causes. Secondly, we have the second most common one is speech difficulties, and it's actually really common, 10 to 35%. So usually speech difficulties happens following a stroke. So it can include dysarthria, just like we mentioned, of speech. It basically involved weakness used for breathing or producing voice and even speech. Lastly, we have the visual field defects with 5 to 20%. The person won't be able to see a section of field due to vision area of the brain damaged by stroke, of course. So most common types, just like my friend mentioned, is hemianopia, which means losing the side of left or right eye visual field. We have always to keep in mind that stroke should be considered in any patient presenting with acute focal neurological defects. Right? So when our patient comes to our clinic, we should know regarding the symptoms, we should know which area or which cerebral artery is defected. So we have the anterior middle cerebral artery and posterior and vertebral basilar system. So each and every one of them, once they get defected, they will present with symptoms. So first of all, we have the anterior cerebral artery is the most common one out of them. Usually, you're going to see the patient in front of you having abnormal behaviors or behavior changes, and that's a really significant presentation that gives you a hint that this is an anterior cerebral artery. Secondly, we have the middle cerebral artery, which is weakness of the upper contralateral face and arms. And usually it presents with speech disturbance. So once you talk with the patient, you feel like he's having a hard time speaking or having abnormal discussion with you, what's called aphasia or dysarthria. This usually indicates that there's a middle cerebral artery. And it also comes with sensory defects related to the middle cerebral artery. And the third one is the posterior cerebral artery. It usually just involves the eyes or visual field defects, and even sometimes sensory defects. The last one, the vertebral basilar system, is think about it. Once it gets defected, it's not lateralized. The patient will be presenting with dizziness, ataxia, impaired balance. He will have a problem or abnormality in eye movements. Even he will have dysphagia, and that's a really, really important point in the situation of patients with strokes. They will have dysphagia, which is a hard time swallowing or even painful swallowing. And that's a really important point in history taking, as well as you will have a decreased consciousness. This is a differential diagnosis of stroke. These things that makes stroke different than others, and to differentiate between these symptoms that are similar to each other and other neurological defects. So we have seizure, usually come with stroke. We have cephalic migraine, and that's a specific type of headache or cephalic migraine that once we present it, we're gonna think and we're gonna rule out other causes and focus more on stroke, intracranial pressure, and even metabolic encephalopathy. Okay, now I'm going to speaking about the history and physical examination of a patient with stroke. So just like any other history taking, just like any other history, neurological history taking, first of all, we're going to open the consultation. We're going to achieve complaint, and we're going to discuss each and every one in the following slides: history of presenting illness, past medical history, drug history, family history, social history, schematic review, and then we're going to close the consultation. So, give complaint. This is one of the most important things, and history is very, very important in stroke patients. So, first thing you're going to do is start your question with what brought you here today. And that's really important. Give us so many hints of this patient's having stroke. So we should give the patient a lot of time and give him his freedom to speak, because stroke patients have hard time speaking. So that's a good point. Second of all, we should pay attention on how the patient is communicating or speaking. That's as well as a very important factor. And we can tell if the patient, or we can ask him if the patient have any evidence of dysphagia or dysarthria, if having even a hard time swallowing.
Fahad?
So, yeah. Hello.
Can you translate this question for me? Go back one slide. Can you translate this slide or this question in Arabic?
Arabic, yeah. So المريض لما يجي عندنا في العيادة احنا راح نقول له ايش جابك هنا اليوم؟ هذا السؤال مرة مهم لأنه سؤال مفصلي قد يدلنا على عرض معين من خلاله نعرف ايش هو الستروك او نوعية الستروك، يعني قد يعطينا انديكيشن من بدري.
دقيقة، الآن لو جاك واحد، أي واحد، لو أنت قاعد بمكتبك ولا بغرفتك ولا ببقالتك ولا بأي مكان، قلت له وش جابك هنا؟ هل هو سؤال كويس ولا يزعل؟
لا طبعا قبلها طبعا تسأل اول شيء how old are you، يعني انه هذا
حتى لو كان لو جيت عند اخوك بغرفته وقال لك وش جابك هنا، تزعل ولا سؤال كويس بالنسبه لك؟
I mean I can say it in a nicer way يعني.
ايوه هذا الصحيح، هذا اللي ابغى اقول لك انا. هذا this is a common mistake in يعني in all the students وحتى بعض الزملاء اللي
عفوا دكتور في مناهجنا كلهم علمونا هذه الكلمه، الجمله حفظونا اياها وكلها موجوده في المناهج وكذا.
طيب ابى اشرح لك شيء بسيطه، هدي اعصابك معي. في نقطتين مهمه. اول شيء دائما الانسان ما يحاول يكون ديفنسيف. طيب دونت بي ديفنسيف علشان مع الناس ما تتضايق منك وانت تناقش. الشيء الثاني انا عارف انه في كثير ناس يمكن في مشكله بالتعليم، لانه كل الطلاب يخطون هذا الخطا لين يصلون الامتياز، وحتى نشوفهم ريزيدنت وبعض الاحيان ستيل يخطون نفس الخطا هذا. فإتس جود تشانس اننا نتعلمه بسنه ثالثه طب، عشان لما نجي نتخرج ونصير كونسلتنت وكل شيء يكون ما نخطي نفس الخطا. What brought you here بالانجليزي is very polite sentence، بس بالعربي جمله ما هي مؤدبه ابدا. تقول الواحد وش جابك هنا؟ فلو جيت لمي وداومت معي بعيادتي بالخاص ولا جيت لمي بعيادتي بالجامعه عندنا بالامام، بتلقاني ما يمكن اقول مريض وش جابك. لو قلت المريض وش جابك بيقوم هو يضربك. طيب فلازم نترجمها بالطريقه الصح. الترجمه مو بس ترجمه مع كلمات، لازم يؤخذ شيء يسمى روح الترجمه. هذه الفكره من الترجمه، ولا كان جوجل ممكن يحل محلنا. فوات بروت يو هير، وش جابك هنا، هذه ترجمه جوجل. بس الترجمه الصحيحه انك تقول سلامات مثلا، سلامات كيف اقدر اساعدك، او سلامات وش المشكله اللي خلتك تجي اليوم، او وش اكثر شيء خلاك تجي اليوم، او شيء من هذا القبيل، اللي هو يعني حس المريض وش انه هذا وش اهم شيء خلاك تجي بطريقه مؤدبه. لانه what brought you here بالانجليزي ما هي it's appropriate in English but it is not appropriate in Arabic. واضحه؟
شكرا يعطيك العافيه.
يلا جو اهيد.
اللي بعده لو سمحت. So history of presenting illness. So there's a really important question that you should ask the patient to test his orientation. So you're going to ask him about the time the location or where he is at the moment, see and test if he's well oriented of his surroundings. So, and even the onset of symptoms is a very important point. When did the symptoms start? Because it might varies if it's stroke, whether it started 2 weeks ago or just a couple of days ago. And of course, the onset if it's acute or gradual. And as well as it's very essential to get an accurate symptoms, because each and every time or depending on the duration, we can there is specific comes with that has to do with duration of the onset, as well as it could help us differentiate between TIA and stroke, which is transient ischemic attack and stroke, because usually TIA occurs less than 24 hours and stroke usually more than 24 hours. Okay, as well as severity, there's a lot of ways to clarify or how weak the patient is, whether you can ask him about how painful or how severe it is from 1 to 10 on a scale. You can ask him about his sensory disturbance. For example, if the arm was completely numb or just a part of it is numb. Even visual disturbance is very important in this case to see how much of the vision the patient is having affected, whether he has dysphagia or dysarthria. There's specific associated symptoms that are related to stroke, just like weakness, just like we said, sensory disturbance, visual disturbance, speech disturbance, and even coordination problem. And headache, usually just like cephalic migraine, just like we mentioned before, nausea, vomiting, and a reduced level of consciousness. And we can as well as ask the patient if you can ask him which hand is more dominant than the other. And if he had any head or neck trauma that could lead to stroke. Okay. You can ask him about past medical history and surgical history, previous similar episode, and that's really important actually. If it's the first time or if it happened before or had previous episodes, and we can clarify the frequency of episodes, how many times it happened, and how and what were the symptoms. Of course, just like our friend said, it could be related to so many chronic diseases, just like diabetes, hypertension, and so on. We can ask him about other medical conditions. If he had any, just like we said, hypertension or any chronic diseases, we can ask him about if he did any previous surgical history, if he's addicted or if he takes any kind of medication, just like aspirin or warfarin. And of course, most importantly, they have family history. If any part of his or any member of his family, like his mother, his father, had history of stroke, that might increase the chance of him developing stroke. Lastly, we can ask him about social history, just like we mentioned, smoking, diet, if he's addicted to alcohol. And then we're going to do a quick systematic review from head to toe to make sure that we haven't missed anything. And then we're going to close the consultation patient. After closing the consultation, after closing the consultation, we're going to do a sensation test for the patient. So first of all, we're going to ask the patient to close their eyes throughout the assessment of this whole sensation test. First of all, we have the light touch sensation. Light touch sensation is basically, it tests the position sense, because some patients may complain about pain or sensory loss. So this one is very important to see basically the position sense. Secondly, the pinprick sensation. Pinprick sensation is sensation of uncomfortable tingling. The person, if you tingle the patient or the person in his foot, or for instance, or tingling or prickling usually is felt in the arms, legs, due to compression of nerves. Thirdly, we have the vibration sensation, which is a sensation that occur or that happen of in the air vibration, such as vibrations sensation. Lastly, we have the proprioception, like he mentioned, my colleague, that it gives us a sense of self-movement and body location that can tell us the patient whether he has good balance, or even if he can control himself and his location. Okay, so these are just another tone and range movement we can do. We can ask the patient to move his arms and legs, not if the patient has any limitations. If he flexed his arms, for example, or flexed his legs, we're going to see if he has any kind of limitation. If he cannot flex it all the way to the end, we can ask the patient to relax his arm while he moves the major joint. That maybe could give us indication if he has maybe tremor or something, who knows. We can support the patient's arm by holding their hand or elbow. We can move the wrists to full body motion to see if there's, we can do the pronate and supinate test. We can flex and extend the elbow joint, just like you said, the legs and the, you can flex the extend the shoulder joint, and we should know and focus on the tone of the muscle and the movement and the smoothness of the muscle movement. And lastly, we have the feeling for rigidity and cogwheeling, and that's really important point in give us an indication of Parkinson's disease if the person have a cogwheel or rigidity. Okay. Lastly, we're going to thank the patient. We're going to cover the patient and wash our hands, and we're going to summarize the findings if we find any abnormalities or any things that we find abnormal, and we're going to do a quick recap to summarize.